Today we'll discuss about facial palsy. The nervous system examination, we are sequentially answering three questions. The first question to be answered is, a patient coming with a particular complaint, is this likely to be due to involvement in the nervous system itself or due to some other thing? Second question is, this particular problem, if you feel likely to be due to a neurological problem, where exactly is the nervous system involvement? It can be anywhere in the brain, cortex, subcortical, internal capsula, midbrain, pons, medulla, or in the spinal cord, or anywhere in the motor unit. That localization, anatomical localization of the neurological problem is achieved basically by the neurological examination. If you analyze the findings and try to put everything together to localize it. After localization to a particular point or more than one point in the nervous system, the third question comes, what exactly is the pathological basis? For the very same anatomical localization, the pathological basis can be any of these things depending upon the scenario. It may be due to congenital malformation, it can be due to trauma, it can be due to a vascular problem like bleed or thrombosis or a vasospasm. It can be due to any sorts of infections. It can be due to other inflammatory disorders. A lot of demyelinations, neurodegenerative disorders. Can be due to nutritional deficiencies, excess or imbalance of the nutritional problems. It can be due to lot of growths. So the pathological basis for a particular anatomical localization, the clue for that comes more from the history than your general examination. The neurological examination may not answer to the pathological basis mostly. So you are trying sequentially to answer all these questions by, of course, the systematic evaluation of the history and the examination. When you take the history, apart from the history points which will give a clue towards the pathology, when you analyze about the complaint, you just go in a bit different manner. So you give stress on the onset, the evolution of the problems, and the course of illness and the present status. So that is important. Whether the onset is abrupt within a matter of minutes, that argues for a particular type of pathology. The onset is a little gradual one over hours to days. Degenerate these demyelinations, infections take some more time, but hours or days. It takes the onset again is a gradual one, takes in months, can be a growth. Just like that, the onset, the evolution of the problems gives some clue towards the pathological basis. Sudden onset and the worst problem within initial part and gradual recovery argues for a vascular nature. Gradual onset and the evolution of the problems over days, plateau and recovery is an argument for a demyelination. Relentless progressions gradually or a much faster manner, taking weeks or months, argues for a growth. So like that. So that's the basic method of analysis of a neurological complaint. Now we come back to the today's topic of facial palsy. So commonest complaint with which the patient comes is all of us are aware the deviation of the angle of mouth, maybe one of eye difficulty closure, sleep mother notice the eyes are open on one side, the other. It may not be obvious except when the patient cried, mother noticed there was a deviation. Like that, deviation of the angle of mouth is the usual complaint. But here one very important thing, all the situations of deviation of angle of mouth means one side the power is normal, the other side the power is less. Then only you will get all the clinical signs. Suppose it's a situation of bilateral involvement, what will be the manifestation? None of these things. Both sides are weak. So it's a subtle thing. Unless you consider this thing, you may miss a bilateral facial weakness, especially partial one. So just think about that. So the first point, is it likely to be a neurological problem? Most of the cases it's obvious, but there are certain subtle things which may be mistaken for a facial palsy. One very important thing is some deviation of the lips which is noticed in a newborn baby. It is from the newborn baby, it's due to absence of depressor anguli ori muscle. That may be mistaken for a facial palsy in the newborn baby. Element facial palsy can occur in the newborn baby due to a lot of birth injuries. When forceps was applied, there can be an injury somewhere here and you can get an element facial palsy. It's not that rare. So in a difficult delivery, you can encounter it, but it's the other thing is more common nowadays because nobody uses these forceps commonly in an obstetric procedure nowadays compared to previous. So depressor anguli oris is one commonest of the simple malformation. Only thing is that there can be an associated heart problem, so rarely. But first question to be answered, I am not dealing with something which look like a facial palsy. Okay. So first question is answered. In this case, it is so easy. Unlike another neurological problem where it may be more difficult. Here, first question is answered. Yes, maybe you are dealing with a facial palsy. Now comes to the second point. Where is the lesion? For that, in the case of facial palsy, you need to analyze the problem first by the clinical examination. So how to look for and how to. For that, before I come to the methods, I'll just go in depth about the anatomy, neuroanatomy. This is the cortex, pyramidal. So all of us know the distribution of the localization of different parts. Here the lower limbs, then comes more area of your hands, index finger. You might have been remembering the diagram, the Hutchison. Lot of representation for the area where minute details are needed. Then comes somewhere here, face is represented. The other things lower down, less and less important areas. So this is the major area where the face is represented. From the facial fibers comes down, corona radiator, then here is internal capsule. I have drawn it as the coronal section of the brain. Here is the internal capsule. Then it comes down. This is the midbrain crus cerebri. Then this is the pons and the lower end of the pons. This part is the medulla. The lower end of the pons. Till then it is this side. It crosses over to the other side. And here is the nuclei. The opposite side, lower part of the pons. Where exactly in the lower part? Is here. I have drawn a cross section of the lower pons here. So an involvement anywhere from the pyramidal in the precentral gyrus down to the upper with the midbrain, upper pons, mid pons, if there is an involvement of this fiber, this is called UMN type of facial palsy. So from here, the opposite crosses the opposite side, it is destined for, suppose you are taking it as a right, you will get left facial palsy here. Element, whatever it be, the facial problem, it is destined for supply of this side. So from here starts the element. So any problem starting from here produce an element, any problem up to this produce an UMN facial palsy. So here is the, I will cover the lower motor neuron also. This is the lower part of the pons. Where is the lower part of the pons? In the side, I draw the brain like this. This is the midbrain. This is the pons. This is the medulla. So fibers are coming like this. This is a crus cerebri. Fibers come like this. This is a pons. It comes down here. I am cutting the here. This is the cutting area. So upper part, this is the midbrain, this is the pons. Here is the fifth nerve. Sixth and seventh nerve are here in the lower part. This is what is written here. See, facial nerve originates. Where is the facial nerve originating? Lowermost part of the pons, very near the midline, in the back, posterior part. This is the sixth nerve. Sixth nerve, opposite sixth nerve also is the sixth nerve has got some very interesting thing. The sixth nerve is the abducens which abducts the laterectus, and this is like this goes upwards through this sixth nerve, goes to the third nerve in the midbrain. This sixth nerve fibers goes through the sixth nerve and goes to the third nerve. This is MLF. So that is important when we analyze these seventh nerve. That's why I have just mentioned the pathway. This side sixth nerve fibers goes this way and goes to the third nerve. So because when I move my left eye, when I look to this side lateral rectus, this medial rectus should be accompanying. Then only I can have a vision like that. Otherwise the images will be separated. So for an image to be focused on a vertebrae, the lateral rectus should be accompanied smoothly by the medial rectus. That happens because this sixth nerve and this medial rectus part of the third nerve are husband and wife. They always move together only. The connection is maintained by the MLF. That is important because there can be an involvement of the facial nerve and these fibers. That's the reason why I talked like that. This is the origin of the origin of the facial nerve. From it goes up and back, upwards, backwards and medially. Then it curves around the sixth nerve nuclei, producing a folliculus in the fourth. This is the floor of the fourth ventricle. Then it goes down, out, downwards, and it exits at the pontomedullary junction on a little lateral part. Here it exits out, facial nerve. So from here onward, this is the cause of the facial nerve. Then here there are certain other nerves which are there in the pontomedullary junction on the lateral part. There are three nerves. Suppose this is a seventh nerve going out. Few more nerves are closely related there. The eighth nerve, two components of the cochlear and vestibular components are very closely related. And one more nerve is the intermedius, nervus intermedius, which carries a lot of autonomic fibers destined for your lacrimal, your salivary, and that is represented internally as tracts which goes down, tractus solitarius. So tractus solitarius is inside nervous intermediate goes out, and actually the fibers are destined for autonomic supply of all these things. So these are all closely related. When it exits out at the pontomedullary junction of the lateral aspect, it enters into a small gap, that is the CP angle. So just imagine the lateralmost part with the small gap, where the eighth nerve two components are there, the seventh nerve is there, nervous intermediate is there, and the cerebellum is so close back. So the very small gap, lot of very important things are there. That part is important in a medicine because there is something called CP angle tumors. There can be a growth on the eighth nerve, which can impair and impinge on the neighboring structures. Backward is the cerebellum. It can involve the facial. It can involve the hearing. So very interesting clinical manifestation you can get by the neuroanatomy. So from there, what happens to the seventh nerve after exiting from the... So far I have covered the course of the seventh nerve starting from the nuclei in the parenchyma of the pons to the exit. After the exit is the area very inside the brain but outside the brain matter, the CP angle. So where it's related, eighth nerve, nervous intermediate, and back cerebellum is there. So once it exits out, how it goes? Once it exits out, after 1 centimeter, it just enters into the acoustic meatus, the tip of the petrous bone, the internal acoustic meatus. It enters, and the rest of the course is through the petrous bone. Who all are accompanying that part? Facial nerve, the two components of the eighth, motor and the vestibular, the nervous intermediates, and then vessels, labyrinthine vessels. All these structures will go inside. Though that's the second part, they goes through the cave. Then what will happen to this facial nerve? So it reaches something called genu. And from the genu is just like knee, is a bend. You have got the bend here, bend onward, then you go down. And after going down, this is stylomastoid foramen. Here, few relations are there. It's very important. From here, genu, it leaves a nerve that's called the greater petrocell. The petrocell and Vigian nerves join together, that is destined for your supply of your lacrimal. I'll tell about the course of this thing later. So anyway, there is a branch destined to supply your lacrimal and tears starting from this genu point. Then down, there are three more nerves. One is meant for your chorda tympani. The other thing, nerves to stapedius. Nerve to stapedius, chorda tympani. Okay, that's enough. Then the two nerves, the chorda tympani and nerve to stapedius. Chorda tympani actually is not a nerve going out, it is just receiving. The chorda tympani is receiving the taste sensation of the anterior two-thirds of the same side, and after a course it enters, and here it enters. So chorda tympani enters here and the upward. So why should you remember? This is the nerve to stapedius. Nerve to stapedius first and the chorda tympani next, I think. Okay. Then it comes out of the stylomastoid foramen. After coming out of the stylomastoid foramen, it breaks into five. You call it as pes anserinus. 5 branches. The upper branch is meant for supply of this frontal belly, then the zygomaticus, then the buccinator, then the mandibular. These are the 5 divisions. I may be wrong. Anyway, divisions of the frontal belly, zygomaticus branch, the buccinator branch, and the mandibular divisions, and the lowermost branch. the pterygoid branch, I think. Anyway, 5 branches are intimately related to your parotid. So important because one of the reasons for the involvement is due to parotid gland malignancies, growth or scarring or injury or whatever. So that is in simple form the facial nerve anatomy. You need to remember this thing when you analyze the problem. So let's now come to the clinical examination. How will you analyze? You answered that it must be due to facial palsy. So how will you go forward? So you do 5 tests, which all of us know. You put your hands on the patient's head and ask him to look up. Why you put your hands on the head? You don't want the head to be raised up. One thing. And one more very important thing, there are 2 bellies. You know, the occipitofrontalis muscle can pull your eyebrows up. Even when the frontalis is weak, the occipitalis, which is supplied by another nerve, that can compensate, that can pull from the back, and there can be an elevation. You don't want the occipital belly to be pulling, so you want to test the frontalis belly only. So your hand which fixes the head serves 2 purposes. You don't want the head to raise. You don't want the pull by the occipital belly. So always fix the head and ask him to look up and see the eyebrows. Is it similarly equally pulled up? Second thing, he assess the eyes. Before I ask him to close, look at the eyes. The inspection of the eyes is important. So why inspection is important? Inspection is so important when there is a ptosis, which is not part of your facial parts. It's part of your oculomotor. But here, it's very interesting thing. There can be some inspection clues about the weakness of the orbicularis oculi. What are they? The intactness of the tone of the orbicular oculi is responsible for the adherence of the lids onto the eyeball. If there is a weakness, what will happen? The eyelids can separate from the eyeball, and there can be an evidence for that. What's evidence? 2 things. One thing is, there is a pooling of the tears between the eyeballs. The tears move sideways from the lateral to the medial in a film. When there is a small gap, that will get collected, and it can be collection of the tears and tearing. So that's a clue that the lids are not opposing closely to the eyeball. One very, very useful clue is, look at the margin of the cornea in the lower part. A relation of the margin of the cornea with the lids. A lower lids a little sagging. You may get a very subtle difference of the palpebral fissures. The weakness side of the palpebral fissures may be a little wider because the sagging of the lower lids. So these 2 clues you may miss if you are not spending some time on the inspection of the eyes. The relation of the lower margin with the lower eyelid. The collection of the tears. And maybe infrequency of the blinks, simple things are useful. So always make sure your tests should not be injuring the cornea, and you should be inspecting whether the tearing is due to already succumbed injuries to the cornea. These are all important prognostically. Then you come to the actual motor thing. You ask him to close the eye. And when you close the eye, what are you looking for? You are looking for at the root of the eyelash. And when you close the eye very strongly, the root of the eye will be immersed. You can't see. If the root of eyes are not immersed, it's still seen the power is weak. And one more thing, you can keep your hands on the eyes and see the vibrations. When you keep your eyes shut and keep your fingers, you can feel the vibrations. May not be there in this case. And one more observation, when you close the eyes, is there a Bell's phenomenon? These are all very useful clinical signs in the eye. And then all of us know the other things. Look at the creases. Is it symmetrical? Is it flattened out on this side? The facial expression. Lot of facial expressions are the ironed out nature of the creases. All the creases. So there can be absence or the hollowing up of these creases. A little bit of sagging. The shape of the lips is very useful. No, the shape is maintained by the pull. This side of affection, the shape it may not be symmetrical. This side may be a little smaller lips half. So you can make out that. A little lower and little lesser ankle very close. Then you can ask the patient to do certain things. This is the buccinator. This is easily tested. Then one more thing, early thing, you can ask him to say this one. You can ask him to whistle. Then lower down the pterygoid muscles you can. So up, down you tested. Pterygoid. So one thing very important you need to remember about the muscle, diagnostic muscle, there are two bellies. One belly only is supplied by the facial, the other belly is by the fifth nerve. So it doesn't matter much here. Anyway, you do all these procedures at this stage and then you ask. This is the point where you are answering. Am I dealing with an UMN facial palsy? Am I dealing with an LMN facial palsy? So from this point onwards, you dividing your approach. You are halfway through. If your answer is, I am dealing with a UMN facial palsy, then the anatomical localization is somewhere above from this point. It is in the mid pons, upper pons, midbrain, internal capsule, the pyramids, pyramidal area, precentral gyrus or the corona radiata, whatever it is there. If your answer is, it is the element, it is somewhere starting from this point in the parenchymal, extra parenchymal up to the target. So you are halfway through. So this question answer is very important. So distribution of this weakness help you. The UMN, it's supplying bilaterally. That's a clue. So if there is one side involvement, the other side will compensate. So, I mean the upper part, UMN, the upper part, bilateral representation. So in a unilateral UMN, you will get the upper part power, normal, and lower top part only weakness. In the LMN, you will get the weakness, the whole part, the elevation, occlusion of the eyes, everything will be affected, means LMN. UMN, this part will be spared and this part will be. What are the catches here? Bilateral UMN, it behaves just like element because the compensation is there. Bilateral UMN, bilateral element look alike. One very important thing, don't take it as an absence of depressor anculi, where lower part is involved, the other part is spared. So with this method, you are halfway through. Suppose I will take hereafter the element part. You come to the UMN later. Suppose your answer is, this must be an element because the distribution is throughout all this. Then how will you proceed? What are the possibilities? The lesion is either inside the parenchyma of the lower pons, or it can be outside after going out. So I'll divide that element into two major components. So first part is to answer, is it an intraparenchymal? And if so, where? Is it here, 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 up to that? So how will you answer that? Now comes the importance of your associated neurological findings. So did you find out? I'm not examining in the manner in which you are taught. Higher function, cranial nerves, motor. No. It's a different practical approach, a problem-based approach. When you see a patient, you are moving forward with another style where you can finish off the examination within half an hour maximum. So what are the things which you need to look into here? Considering the anatomical relations. So what are the anatomical relations of this thing? Which will answer where is it? So first thing is, relation is the sixth nerve. So what are they going to find out? Just you see the lateral movements of the eye. So I'm not even looking for the upward, downwards or anything. So they're all important in another context. But here what I want is it involving the sixth nerve? So just test the sideways movement of the eye. Is it full or not? Ask him whether there is a diplopia. So if it is not diplopia, if the movements are normal, sixth nerve is intact. So suppose there is an involvement there, what can be there? There can be, when I look like this lateral rectus is not moving. So what will I get? A diplopia where the images are widening as I look to that side. That means the same side, sixth nerve is involved. The other way around, when I look to that side, it's not the sixth nerve only, it's not the diplopia. But what is observed? The gaze as such is gone. This eye is not moving, this eye also is not moving to this side, but this gaze is normal. So it's not the isolated lateral rectal palsy, it's the gaze. So is it possible? What does that mean? Involvement, you see, if the involvement is here, the facial nerve is involved here, and the sixth nerve nuclei is involved. I told you earlier, when there is an involvement of the sixth nerve nuclei, it's not a sixth nerve nuclei only. It carries the fibers on the opposite side. So when there is an involvement in the posteriormost part at the sixth nerve nuclei, the involvement will be the gaze. So element facial palsy with a problem of gaze to one side means the involvement is in the posteriormost part at the level of the sixth nerve nuclei. So what about the involvement somewhere here? It is the seventh nerve plus sixth nerve which we just talked. Isolated sixth nerve, abduction problem with an element facial palsy. That indicates it's not in the posteriormost part, it is a little in the front. Then, what more? What more you need to test? What is the fibers here? The lowermost part of the pons is containing a lot of fibers. If it is in the side lateral way, it is here. The ascending and descending tracts, a lot of them. The Horner fiber is the sensory fibers going up is the, a lot of fibers going down are there. So just for the practical purpose, you just talking about the pyramidal fibers. The pyramidal fibers are here. So if the pyramidal fibers are involved, so what will happen? Is it going down and it is destined for the opposite side? Opposite side involvement lead to weakness of the upper and lower limbs. So what will you get? The crossed hemiplegia. The opposite side weakness of both limbs. So in the context of a seventh nerve involvement with a motor weakness of the other side means there is involvement a little in the front because pyramidal fibers are going through the front of the pons. So this very simple two tests you need to look for: sideways movement of the eyes and the pyramidal signs in the limb. If there are tone, spasticity or early stages hypotonia, reflexes of exaggerated on one side, upgoing plantar on that side. That means you pinpoint the lesion to be in the pons in the anterior aspect. So if there is an associated sixth nerve also, it's possible. So sixth and seventh and the pyramidal, you are dealing with the problem in the anterior part of it. So very simple, if there is a long tract sign of the pyramidal, if there is a sixth nerve involvement on the same side, the lesion is intraparenchymal inside the pons. Suppose there is no pyramidal long tract sign, sixth is normal, no gaze problem, it's not a intraparenchymal lesion. There are a lot of intraparenchymal problems likely, but here I am not coming to the pathological problems now. So it's not an intraparenchymal. Then what are the possibilities? It's after coming out from the parenchyma. Next, what is the closest relation here? Eighth nerve, hearing, vestibular, and the nervous intermediates which are destined to go out to supply the motor for the lacrimal and the salivary. So that's what you are going to test. So what are the next thing to be tested? To differentiate whether it is a CP angle, whether in the petrous, whether it is a little down. So what are the things to be looked for? First thing is the hearing. Is there an involvement of the hearing? Is there an involvement in the taste? Is there an involvement in the lacrimation? Now you test that. So, three things: hearing, you test the sensation, the saliva, the taste sensation, test for the lacrimation. Simple test. Lacrimation by the filter paper, Schirmer test. Hearing, just like any other Weber or Rinne or whatever, test. Then the quadratic tympani I said, hearing I said. So after you test the hearing, there are two patterns. One thing is hyperacusia. The other is absence of hearing. Hearing is lost. So what does that indicate? If there is absence of hearing, what does that indicate? It can be involvement from the CP angle outwards. For you to get the hyperacusia, what does that mean? Hyperacusia means two conditions. The proximal part of the eighth nerve is normal and it's due to the nerve to stapedius weakness. So that is helpful. An intact eighth nerve and involvement of the nerve to stapedius is needed for hyperacusia to occur. The hyperacusia won't be there when there is an involvement of the eighth nerve. So hearing is very important test. Then lacrimation. So what does that mean? Lacrimation can be involved because lacrimation fibers goes from here. So if there is any involvement here, you lose the lacrimation. If the involvement is distal to the chorda tympani, the taste will be intact. If the involvement is anywhere proximal here, taste will be gone. So that's how you are trying to localize. It is paired. Chorda tympani is paired, nerve to stapedius is paired, everything is paired. That means this distal. So taste is the, lacrimation is the, everything is the, it must be a very distal thing. So after testing these three things, you can pinpoint where exactly in the facial path the involvement is. But there is a catch here. One of the commonest reasons for the facial palsy is the Bell's palsy. All of us learned Bell's palsy produces nothing. Lacrimation will be intact. It's a stylomas or foramen inflammation. No. In certain percentage of the cases, you can get an extra lacrimation. There can be an involvement of the taste. So don't argue that just because it is involved, it is not facial palsy. Facial palsy can have a range of inflammatory signs because it can extend upwards. So it's just a method to pinpoint where exactly in the axis after the okay. In the involvement and the analysis, you need to check two things for the pathology. So I'll come to the pathology part. Okay. Then one thing, the last part I didn't tell you. There can be an involvement of facial nerve after coming out. How can you find out? There are very interesting things, so very important also in our setup. The involvement after coming out from the coelomastoid foramen, I said, you need to look for the injuries, the surgical scars, or the parotid. Very, very, very important. If there is a tumor, if there is a surgery, scar, can be due to injury or a tumor. But one very important thing which is so relevant for all of us is leprosy. Leprosy is one very important involvement of the facial nerve branches. Can involve isolated branches of the facial. And interesting thing, you have learned about the distribution. LMN will involve the entire thing. UMN will spare the upper and lower. What about the leprosy? Leprosy can sometimes involve the upper part only and spare the lower part. That's the opposite. You might have seen a lot of lepers. Well, if they can't close the eye, eyes are exposed, corneal injury and the loss of blindness. So leprosy is such an important condition where there can be an involvement of facial. So, very simple manner, you have pinpointed where exactly is the anatomical localization. So now comes here UMN. So how can, suppose your examination showed it's an UMN facial palsy, then how will you pinpoint? Depending upon again the anatomical localization. Suppose the pyramidal, the precentral gyrus is involved, you may get other evidence of the gyral involvement. So associated seizure, focal seizure can be the subcortical and internal capsule, the hemiplegia, dense hemiplegia. The human facial palsy you will get the same side human palsy and the hemiplegia. The long tracts are involved from there itself. There can be other manifestations depending upon the site. If the involvement is somewhere in the midbrain, you will get clues of the same side hemiplegia with the third nerve involvement. If it is in the upper part of the pons, you will get again the same side hemiplegia with the fifth nerve involvement. So like that, based on the associated findings, you analyze the human facial palsy. So what did we do now? You localize the anatomical localization of the facial nerve. Now you are applying the pathological basis. What is it due to? The very same thing in the parenchymal localization can be. Suppose your answer is anatomic localization in the lower pons in the posteriormost part. It can be due to a vascular, it can be due to a demyelination, it can be due to a tumor. So any of these things. So your answer is coming from the history. What is the onset, evolution and course of the illness? Just like that, even when your answer is somewhere in the CP angle, there again possibilities are, is it a tumor, is it an inflammation, like that. So we are applying the pathological basis from the history, from the clues in the general examination which may argue for the pathology. The infection, inflammation, tumors, like that. So in short, what we do, when systematically answering, is it a neurological problem, where is the lesion, what is the pathological basis. So in very short words, this the just approach. So we'll come with another thing in the next class.